Hello, you're listening to the latest season of the COVID Inquiry podcast. This week, Nicola is joined by Lorelei King, actor, screenwriter, narrator, and most pertinently, a member of the COVID-19 Bereaved Families for Justice group. Together, they're going to reflect on how the recent hearings went and look forward to the next few days of evidence. Please note, some listeners may find the contents of this podcast distressing.
Hello everyone, I am Nicola Brook and I'm the solicitor at Broudie Canter with day-to-day responsibility for managing our work on the COVID inquiry on behalf of the COVID Bereaved Families for Justice UK. I'm here today with my co-host Lorelei King as usual. Lorelei is a member of the group, having sadly lost her husband Vince to COVID. Joining us today to discuss the hearings this week is Lara Wong, who gave evidence in week 1 on behalf of clinically vulnerable families. Welcome, Lara, and thank you for joining us.
Thank you so much for having me.
I'm so glad you joined us, Laura. I wonder if we could start by talking a little bit about your evidence in week 1 of this module 4. I found it. I had some real revelations in the past couple of weeks in this module, and you talked about the difficulty of getting virals and prophylactics for people who are clinically vulnerable. Could you tell us a little bit about your testimony around that?
Yeah, thank you so much for focusing on this topic, actually, because I think it's something that we have always been very concerned that would fall through the cracks of the inquiry, because for clinically vulnerable people, antivirals and prophylactics are really key. However, it's problematic because it only affects us. So we are a relatively small group of people who are impacted by this, but hugely impacted. And so antiviral treatments, I'll just kind of explain what they are to make it clear. Antiviral treatments, once someone has been infected with a virus, in this case COVID, antiviral treatments are very useful, and they can help to treat the infection and make the sort of impacts less. Potentially that person might not have to escalate their care and end up in hospital, or maybe they will not end up in ICU. And the sooner that you receive this treatment, the better it is. It's like that exponential growth that we talk about, the virus in the community, where it sort of started to go low and then it shoots up. And it's like that in your body. So where you have a viral infection in your body, it starts off low and then it starts to rise quite rapidly in your body. And so after 5 days, antiviral treatments, they're significantly less effective. So when people have to access these treatments, they need to access them rapidly. And it's something that we've put in our written witness statement, but we haven't given the time in this module, and for us this module is way too short. It's really problematic because it's a huge issue. It's a huge issue going forward. If we're talking about protecting vulnerable lives, we do need to be considering these particular issues. And so it's not just about the vaccines for the general population, or even the vaccines for clinically vulnerable people. It's about the treatments, should people be infected, and how we kind of move forward. So antiviral treatments, very key. And yes, we've really struggled to access them. We found that people, when they needed those treatments the most, they were referred to their GP, or they were trying to get treatment. They go through the normal pathways, and they would contact 111 or their GP, and then they would go in what we called looping. They would be sent backwards and forwards between the two because nobody knew how to get them these urgent treatments. They had to have a positive test. And if you remember in the early days, that meant having a PCR test. And PCR tests were really problematic. They were given PCR tests which were called priority PCRs. You would put them into a special priority envelope that was a bright red, and it would go into the post box, and then it would be processed faster than the other ones because they needed to get these treatments. But sometimes they'd come back and it would be, the result would say, well, we don't know, you've got to retest. there was a problem with this batch of tests. And so that person who, it takes a couple of days at least to get that back, there's problems with the postage and whatever, it was not ideal. So then your timer is just ticking away, and the growth of the virus inside that person's body is increasing and increasing, and their risk, increased more and more. And many people found that they couldn't access these treatments. And when I say many people, it was significant proportions of people that we're talking about. We heard from various different trusts that put the level of people who were being treated, and bearing in mind the people who are being referred for treatment should have been those who qualify for treatment, at 14%-ish. 14% of the people who should have received treatments, and they were being told, it was like a Goldilocks kind of point, you're too sick, you're not sick enough, but actually treating someone early is so key. It's so important to give them the treatment in the first day if you can, really, really urgently. We managed to kind of feed in information to the system, and there was a change made so that then lateral flow tests were accepted. But lateral flow tests that they accepted had to have a code, had to be an NHS code. If you purchased it from a shop, that meant that it wasn't on the system. So you had to then, test with their tests to be approved as having a positive. So there were so many problems with the process. People couldn't access the treatments. And so, that 14% that we spoke about earlier, that's of the people who knew, who got referred through the system and got to the end point, and then they were told by the clinician, yes or no. So, and to take you very back, to the very beginning of the inquiry, where they had these introductory videos, they had a video from a clinician saying how great these antivirals were and how life-changing they were for the people who received them. And certainly for the people who received them in a timely manner and it was beneficial for them, that was great. But, we have members, and it's awful, members who cross over with your group, who didn't receive treatment in time, and it was catastrophic. And we don't know if that was the key issue that, but we do know that, if they had received a treatment early, their outcome would at least have been better. They'd have had a better chance. And so, it's something that we really wanted to raise. We really wanted more attention on this. And we're so kind of concerned. And I can talk about Evershed later, but I'll give you an opportunity to come in on that.
I just wanted to say one thing I noticed, the whole talk about, and I really do want to talk about prophylactics, which I hadn't even heard of, but whenever I talk to my friends and family in the States throughout this period of the pandemic, they were automatically, it seemed, prescribed, I don't know how to say it, Paxlovid, which is an antiviral.
Well, that's how we say it.
Paxlovid. And yet I never hear of it. I didn't hear of it in this country. Was it not in white? Is this the kind of antiviral treatment you're talking about, that you had to go through this
Yeah, so there are a number
get?
of different treatments, and you've probably heard of some of them, but maybe not all of them. You might have heard of remdesivir. That's certainly one that Donald Trump received when he was being treated. They threw everything at him at the time. But yeah, so sotrovimab is one that we can still access today. There's also like molnupiravir. There's loads of them, and they very often have very complicated and difficult names to pronounce. But there are loads of different ones at different times. They weren't all suitable for everyone, and so where you raise Paxlovid is fantastic treatment, and it has really good outcomes still, and not all of them work anymore. So molnupiravir, for example, has been withdrawn. It is not effective anymore, or not effective enough. But yeah, so Paxlovid is a fantastic treatment, particularly if you are a healthy person. So a healthy older person would benefit a lot from having access to Paxlovid. It has lots of contraindications. So if you have certain medicines or conditions, it might not be appropriate for you. And so obviously, that process of going through the clinicians to just determine what is the best treatment for that person, is so important. Paxlovid is the most effective treatment that we have available today. And yeah, it's a pill form. It's really kind of easy once you've got access to it to give. Not the nicest treatment to take, and it can leave a horrible taste in the mouth, but that's like a small price to pay ultimately. So I think many people are quite happy to access it if they can. But yeah, so America had a much more open policy on this, and I think pretty much anyone could access it there. Whereas here, it's been highly restricted. It's been a very black and white approach to who qualifies for this treatment. And so if you're on the list, you're on the list. You might have multiple issues that puts you in a really high risk category. You know, you might be elderly, really high risk, and you're not on that clinical list, and so you're not eligible for treatment, not unless you're in hospital. And then there were some other options that they had available in hospitals, but that would have been further down the line. So, you know, it's more kind of a Hail Mary type approach to at that stage, unfortunately.
I wonder if I could ask Nicola, I don't know, you may not have any insight into this. Do you know, can you, why antivirals weren't more widely available in this country?
So the evidence that has come out during week 2, we've had a number of the high profile scientists like Chris Whitty, like Jonathan Van Tam. It's been put to them just as it was put to Matt Hancock in week 1. This question of were antivirals and therapeutics, were they considered a lower priority than vaccines? And everyone has said, no, absolutely not. When we started out, they were both the priority. But that as time went on and progress was being made at speed with the vaccines, that everything seemed to shift focus. And yes, they were still going to work on the therapeutic side of things, but actually vaccine was always considered to be the way out. And this is how everyone will be immunized against COVID. And if everyone's immunized, then people won't need the therapeutics. That seems to have been the train of thought, but that ignores the percentage of people for whom the vaccine isn't effective enough. So post-vaccine, they still get infected, or the cohort of people for whom a vaccine can't even be taken at all. And they just seem to have been forgotten about. The counsel to the inquiry has said that overwhelmingly the vaccine program was a success. Well, for many of us, it was. But for those people who were injured by it, it wasn't. And for those people who couldn't take it, it wasn't. And those people just seem to be almost considered an acceptably small number. We can cope with that because at a population level, we did great. But that's forgetting that these are real people with real lives who, some of them, some vaccine injured people have lost their lives as a consequence. And it's just forgetting that there are real people who haven't had the successes that are being celebrated.
I think too, some of the evidence that came out, I think it was in week 2, and I can't remember from whom, but it was also that it was considered that shielding was enough. They're shielding, they can keep shielding. I just wonder, Laura, have I got that right, and what your view on that is?
Yes, and it's heartbreaking for me when you talk about they can keep shielding, because people are still shielding. You know, people who have no route out here, and and if you think back to the beginning of the pandemic, and you think back to those stories, those awful stories, the people who lost their lives, the people, you know, when they were explaining about them, and they would put up a picture, and you know, they would talk about your loved ones, and they would say, and they had an underlying condition, and they had an underlying condition. And it was almost as if to kind of reassure people, well, it's not you that needs to worry here. It's these other people, and kind of, well, you know, they were old, or they had this condition, they had it coming somehow. And it's, you know, people were kind of considered as disposable, as if their lives were kind of had no value. And but also equally bizarrely, the same group of people were blamed. You know, it's like, well, we're not looking down because, you know, protect the NHS, save lives. You know, save lives was this focus. And it's like, well, we're looking down for you. We're looking down to save your life. You know, and yet people who were shielded were kind of told to lock down sooner, for longer, for harder. And then they weren't told anything. And their risk may not have changed from the beginning of the pandemic. They may not have any immunity to this virus still. They're still living in that same state. And so, you know, where is the out for them? How do they then get their lives back? What is the route back? And what it should have been, and what you know, Dame Kate Bingham also discussed in her evidence, is Evershed. And it was this decision around Evershed that was so critical for the most, when they talk about the most vulnerable, for these people that they know are always at risk from lots of things. Yes, doesn't mean that they're definitely going to die. And you know, there is something we can do. Sorry.
No, I just wanted to say quickly, this is a subject I'm really keen to talk to you about because just to say this ever shield, I don't know the name of it, but it's a
Evershed, yeah.
prophylactic. It's a prophylactic. And this is one thing I learned from week 2 of the inquiry is I didn't know such a thing existed. So I'm really keen to hear you talk more about that because I'd like to learn more about this. And yes, I agree. Kate Bingham's evidence on this topic was
It was, yeah.
explosive.
Amazing, yeah, and stunning in a way, in an awful way. But yes, so Evershed is it's well, we use the term prophylactic, but it is an antibody. It's a man-made antibody treatment that was designed to target you know, the early SARS-CoV-2, very much like the vaccine that we you know, that we were all given to begin with. So it targeted that particular variant of the virus, and it's like the immune response that you will create in your own body if you've got a functional immune system. But you know, for these people, they don't necessarily respond fully or even at all in some cases to the vaccines they receive. And you know, and I don't want to put anyone off getting a vaccine because there is really strong evidence that it does make a difference to receive vaccines for this really vulnerable group. The people who don't respond at all, obviously, they're not going to know that that is them. But for the vast majority of them, it does make a difference, and that small difference might be enough of a difference. So really, you know, I don't want to discourage anyone from taking a vaccine or thinking that they shouldn't. But this treatment would have bolstered their immune response. It would have made them sort of more kind of comparable to somebody with a functional immune system. And it would have enabled the freedom that everybody else has enjoyed, you know. And so it was just so awful because, you know, when they've spoken about this treatment, they've put, you know, kind of loads of excuses. They said shelf life, they've said the cost, you know, and actually throughout the inquiry, we're starting to now see these things that are getting unpicked because, well, shelf life, Kate Bingham said, you know, we didn't know what the shelf life was going to be. This was a new product. And we found the same thing with antivirals, you know, that they started with a certain shelf life because they can only give a shelf life for the period of time for which that product has existed. You can't claim that it has a longer shelf life than it, you know, this thing has never existed beyond that length of time. So, you know, so shelf life was a very strange argument. And the cost, well, Kate Bingham said herself, you know, the cost was going to be nothing up until the point that we'd proved that this treatment did work. And their argument was, and Evershed went through a unique process. It was treated differently. Everything else was given, including the antivirals, emergency approvals. So people were able to access them much more rapidly. Whereas Evershed was forced to go through the NICE approvals process and NICE looks at, you know, how cost effective a drug is and whatever. And so it went through this prolonged NICE process. And during that time, well, guess what happened? As we found with the vaccines, over time, they became less effective and we started getting, and so by subjecting it to this additional scrutiny, they forced it down a path which meant that it was going to be far less effective. And it didn't mean it was completely ineffective, and we will find later on when we get to the evidence that will be offered by the expert on this topic, that that there's no actual guarantee that that it was completely ineffective, and actually we should have carried out trials in humans rather than trials in test tubes, and that's the real kind of crux of it for us, that they treated it differently, and the outcomes for this group that was blamed for everything, was that they're in a perpetual lockdown. They haven't committed a crime. They're under house arrest, essentially. Many of them, they're limiting their lives. They feel they can't access healthcare. And when I've got some data, but not specifically related to this group, but the more broad clinically vulnerable group. I regularly poll a group on various things, and I polled them on access to healthcare and how the pandemic was impacting on them. So airborne viruses in healthcare, how it had risked them. I previously polled just on COVID and how it's affecting their access. And 88% of people told us that they have or they would delay or cancel their medical appointments due to these high risks. And so there's this indirect impact of the presence of these, and the fact that we're not dealing with airborne transmission in healthcare. The indirect impact is that we're still going to lose people's lives because they're not being treated for their other conditions.
I really want to come back to the airborne thing in a minute, but you just touched on Kate Bingham there. She is the former chair of the vaccine task force, and I have to say, in week 2, for me, her evidence was, I think, the most explosive. Nicola, I wonder if you wanted to talk about that.
I completely agree with you about Kate Bingham. What a force of nature. Everyone has spoken about her in glowing terms and said that essentially the appointment of her was a genius move. It seems really odd to put someone in charge of the vaccine task force who doesn't come from a scientific or medical background. I believe she's a venture capitalist, so like a purely business background. But it really seems that that was precisely what was needed in order to drive this through. Her evidence was so quick and to the point and direct. And you can just imagine that's how she was conducting all these vaccine task force meetings. The fact that even prior to her appointment, she insisted that she had a direct line with the Prime Minister because she could foresee all the machinations of Whitehall and how that would be used to stall progress. From the very outset, she seems to have seen exactly how things needed to be done, anticipated it, and put things in place that meant she was able to get things done the way they needed to be. Also, the fact that she wasn't from Whitehall, I think that has enabled her to be far more honest and direct in her evidence than others have been. You contrast her evidence with the likes of Christopher Wormold. She talks about there being open warfare between the business department and the health department. Nobody else has been using such direct and honest language like that, and talked honestly about just how difficult it was to achieve things, even though everyone was working with the same goal in mind. So yeah, a complete breath of fresh air, even if you don't agree with all of the decisions that she made.
One thing she said that I'd like to come back to Laura about, she said she was very frank, as you say, Nicola. She said there was zero appetite to consider how immune compromised people would be treated. She just said it was cheaper to let them shield at home, and if they got infected, to let them be treated because of the costs. She said that quite clearly. She said there was no appetite to buy therapeutics, and she said that she considered this unethical. And she said there was no reason that the vulnerable should have been deprioritized like that. Can I come to you about that, Laura?
I just find it mind-blowing. The whole thing just didn't make any sense to us. And in terms of deprioritizing this group, I mean, the problem is they had no voice. You know, who is speaking for this group? You know, who's arguing back on this? And they're really vulnerable, and they've got all these health conditions, and you know, they're struggling. Maybe they've got cancer and they're really sick. You know, how can they fight their own kind of health condition and fight the government without a voice, without any access? You know, it was just such a kind of a shocking situation. And obviously, yes, Kate Bingham could see this, and she knew, and she argued to have you know, prophylactics as part of her brief. She didn't want to kind of lose that once the antivirals kind of task force came along, and it is more kind of an equivalent to a vaccination. It's so whilst there are similarities between these treatments, man-made antibodies can be in both of these products. Evusheld has an ability to remain in your system for much longer, so it has an additional factor in there that's been added to allow it to last for at least 6 months, and so it provides this kind of ongoing protection to people, and it's a really vital thing, and it's something that we have. You know, prophylactics aren't new; they've always existed for other things, and so we do need to consider this group, and it's just quite shocking that the pathway that we took and the fact that we didn't invest in these treatments, and Kate Bingham spoke about the numbers of people who they wanted to get treatment for, and they said that 500,000. Certainly, having read the NICE document on this, it was obviously written, well, the particular number came from AstraZeneca, but they pointed to 1.8 million people that they felt needed treatment with this product. AstraZeneca couldn't supply that many people, though. That was the problem. And so, you know, when they tried to order it, Kate Bingham explained that they had to reduce their order, and they reduced their order to 50,000. So, you know, 1 in 10 of the people that they'd originally suggested. And then once they had suggested that number, then the government backed out and left those people with nothing. And it was hugely problematic. I mean, we ran petitions, we tried to raise awareness, but ultimately the decision is with the government. And if the government didn't support it, if the government weren't going to fund it, and they might say it's quite expensive, but you know, if you're talking about a drug that gives somebody their freedom, you know, what price do you put on that? And they could not even buy it privately. There was no route for anybody to access this treatment. Now, ultimately, once it passed through NICE and it failed to be approved by NICE, we found that, because I'd been contacting AstraZeneca repeatedly to try and ask them, you know, was there anything else we could do? Could they at least make it available privately? It'd been approved by the MHRA as safe and effective. You know, I've been asking them for, you know, long before this approval process, would they be able to do this? And they came back to me after they were rejected and said, you can access it, and we'll explain to you how to go to Poland. So all of our members got really excited, not all the people who would have been able to access it. You know, you needed your doctor kind of referral, and you would need to get to, I mean, you need to get to Poland safely. I mean, I don't know how you would do that. Anyway, a week subsequent to that announcement, I mean, their phone line went down within minutes. You know, there was so much demand, and people were willing to, even though they didn't have the money, they were looking to friends and relatives, and you know, how could they fund this treatment? And yes, they made it available privately, but the point at which they made it available privately obviously was the point at which NICE had said, no, it's not effective enough. So then there's a real concern, because it's like, well, if it isn't actually effective enough, and you take this treatment and you take this risk, and you are really high risk, where does that leave you as well? So the whole process, everything that happened, you know, was just hugely problematic for people. And yes, so some people did buy the treatment, and did start living their lives to an extent, but because we didn't support it, you know, that there haven't been as many generations of it. There's another generation that AstraZeneca are working on now, but it's not looking positive already because of the, you know, the process takes so long. And so Evusheld, or Evusheld, whatever the future version of that was going to be called, is off the table. But there are other prophylactics that are on the market that could be suitable. that we are also not considering. So, you know, it is not just this one product. We shouldn't just focus on one.
I understand. I can only imagine how a group like yours, uh, clinically vulnerable families, must feel when they hear testimony like we heard in week 2, that it was a matter of cost, a group that's already so marginalized. I can only imagine what that's like. Nicola, did you want to come in on this?
One of the things that struck me when Chris Whitty gave evidence, he was talking about antivirals, and he was trying to explain how pre-pandemic this was one of our weaknesses in the scientific research. And then he said this: we didn't have very many antivirals to put into the system. The science simply wasn't there. At the end of COVID, we didn't end up with a large portfolio of good antivirals for coronaviruses, unfortunately. And the problem there is, he said, at the end of COVID. COVID isn't over. And for those people who are clinically vulnerable, it really isn't over. Yes, the kind of acute phase of real fear of those awful images of people lying in corridors in hospitals, that bit isn't as bad as it once was. But COVID hasn't gone, COVID isn't over, and for clinically vulnerable, it's still very much a real fear. And it brings to mind, Lara, what you said when you gave evidence about people in your group going for the vaccine, and how everyone there was great at cleaning up and wiping down seats, but that wasn't what your group was scared of. What you were scared of was the airborne transmission routes, and how there was no protection for clinically vulnerable going into a vaccine centre to get the thing that would supposedly free them, and yet the very place they are going could be the place that presents a danger to them.
I'm so glad you brought up airborne, because I wanted to talk about this, ask both of you, but Laura especially, because the debate about airborne still goes on. So many scientists see evidence. We heard it in module 3, certainly, of COVID is airborne, and yet you have people very high, and the IPC, you have people saying it's droplet, still spreading this, what I believe is misinformation. And I just wondered about your thoughts on that.
It's hugely problematic, and it's particularly problematic for our group who continue to try to make efforts to protect themselves as much as possible, not just from COVID, but obviously, you know, flu and other airborne infections. But we do have more tools, you know, available now, or at least we're more aware of them, let's say. So, you know, our group, very early on, I was quite keen to explain to people about better quality masks. I still see people wearing, you know, the surgical masks, which do make a difference, but not as much of a difference as we would like. You know, an FFP3, which is like an N99 in the US, can provide over 99% protection from airborne particles. Obviously, it has to be well fit, and there was this huge argument around fit testing in module 3, and I would say I found that absolutely mind-blowing. The way that they were making perfect the enemy of good. They were saying that if you haven't had this fit test, then suddenly it doesn't work. You know, if you're I'm going to use the example of swimming goggles, but if you go swimming in a pair of swimming goggles and you haven't had them fit to you perfectly, but they're going to still kind of keep the water out from going into your eyes, you know. It might not be the best pair of goggles for you, and maybe they leak occasionally, but they still, you know, they still work generally. And if you are aware of any kind of issue, you're going to get rid of those goggles anyway, aren't you? And that's the thing, you know. I think saying that, you know, a mask that clearly is gappy on the sides, that you can see giant holes in, saying that might be somehow better, which is what Chris Whitty was saying. There's evidence that it's better. It's madness. They talked about trials, and they said, you know, we don't have this gold standard like RCT trial evidence, which is where you can compare. Then you can have like double-blinded trials or single-blinded trials where the participant doesn't know, and it's usually for drugs. So or the vaccine trials we heard about in this module. The vaccine trials, they'll give them a vaccine. They might give them a different vaccine. That might not be a COVID vaccine, might just be another, and then they compare and see what. And so sometimes they'll give them there's like nothing, it's just water or whatever. And then they compare, and then they say, what are their outcomes? What symptoms did they experience? And that's obviously where you're looking for the potential vaccine damage type issues. But with a mask trial, and think about this, you can't perform an RCT. It's not possible to not know which mask you're wearing. How can you be single or double blinded in the mask that you're wearing? So how can you ever, the bar that they've set is impossibly high. You can never get the evidence that they're asking for to then say, well, this is the right type of mask. And Professor Beggs gave his his feedback on that kind of idea and said, it has been proven mechanically. We know that it filters this much. And yes, you have to fit test if you want to make it filter precisely that much, or at least that much. But to tell people or not to tell people, and we told people to wear face coverings. And what were face coverings? They were not PPE at all. They were a scrap of fabric they cut from a t-shirt and they tied around their face. It was a scarf that they wrapped around. Face coverings are not PPE. Surgical masks are not PPE. The only ones that were PPE are FFP2, which is 95%, same as an N95, or FFP3, same as an N99. They were the only ones that were proven for airborne. And yes, we have this real problem when we enter healthcare now. Healthcare professionals, and it's awful. Many of them, if not, probably all of them, have been traumatized by their own experience of the pandemic. Wearing a mask, seeing someone wearing a mask can be very triggering for people. We don't have a choice. We continue to mask because, our only choice is to choose to protect ourselves. And so then often we get these comments from medical people who do know that these are protective masks, who say, you don't need that now. You don't need that now, as if it's in the past. Wei Shin Lim said, this is not a seasonal virus in his evidence. We know this all year round.
I really agree with you. Earlier, something you said about it's like there seems to be this attitude that if you can't do everything, do nothing, which is ridiculous. Nicola, can I come to you?
One of the most frustrating parts of the Module 3 hearings was this ridiculous evidence from those connected with the IPC cell saying that there was no evidence outside of the laboratory that proved the FFP3 masks were superior to the FRSM surgical face masks. And we kept banging this drum that the absence of evidence is not evidence of absence. And Jonathan Van Tam kind of said that in his evidence in week 2 on a slightly different point. So he was embarrassed by an email that he had sent in which he said there is no evidence that vaccination of healthcare workers protects their patients or residents. And he was at pains to say that that's not really what he meant, and he was using this medical language. He said, when I say there is essentially no evidence base for this, it doesn't mean that vaccinating healthcare workers doesn't protect residents. It means that no one has studied it, and therefore no one has generated the evidence by which I can say there's proof that it will prevent infection. And so they were able to make that point in Module 4 about vaccination. But when we tried to make this point in Module 3 about face masks, that didn't go anywhere. And they were allowed to get away with continually saying there's no evidence for this. And it just seems to me that some experts or scientists are able to use this medical language when it suits and to manipulate the interpretation that is placed on it. And it struck me when Jonathan Van Tam gave that evidence, I think on Monday of week 2, that the parallels that you could draw.
We also had a lot of high-powered the scientific witnesses this week, and one of them was Jenny Harries. Nicola, can I come to you for your thoughts about her testimony in this module in week 2?
Sure. I think that this was a real low point for me in this module. She gave evidence about various matters, but she was particularly asked about the order of prioritization. And it was put to her that the witness who gave evidence on behalf of our group, Helena Jean Rossiter, she gave evidence in week 1. She lost her son, Peter. He was just 39 years old. He was a teacher. For much of the pandemic, he looked after the children of key workers. And yet, despite that placing him at greater risk of exposure, he wasn't prioritized for the vaccine, and he had to simply wait for his age group to be called up. And when this was put to Dame Jenny Harries, I thought the way she answered it was just so condescending towards our client, so belittling, and just really lacking any compassion. She said, yes, I did watch that, and I think she'd be quite interested to know the logic behind our decision. And I just thought, wow, you may have listened to her evidence, but you didn't hear. And she essentially said that someone had put to her a pilot, and this came from Liverpool City Council, and it specifically talked about prioritising vaccination for teachers, because they were around children all the time, and they were known to be carriers, even though they weren't at increased risk themselves. And her answer was no. The prioritisation is based on saving lives, and the teacher cohort, unless they're vulnerable, they are not at increased risk. They are the same as everyone in their age group. The children themselves don't seem to be getting seriously ill. And if the teachers are clinically vulnerable, they would have already been vaccinated by now. And it just seemed to completely ignore this, the fact that by being around kids all day who wouldn't have had the same discipline about social distancing, place teachers at greater risk of exposure. And I think actually when she came down to the truthful answer, it was that would open the floodgates. And then there would be other groups saying they should be prioritised. And I can understand the difficulty around that. But for someone who works in public health, it's very clear that her concern is at population level, and actually the individual is allowed to get lost in that.
I agree. Laura, were you able to catch her testimony?
Yes, I was, and I should be clear here that my background is science teaching, so I have every sympathy for your member and their son. It's awful, and I very closely followed all of those kind of discussions at the time around teachers and prioritization and what they were going to do, and I don't agree with what Jenny Harries has said. I don't agree that all clinically vulnerable people were vaccinated at that time. Even if they were, only clinically extremely vulnerable people had 1 dose. Clinically vulnerable people, most of them, well, they hadn't even been offered them at that point, I think. So it was only clinically extremely vulnerable people. And so they weren't fully covered. People who are severely immunosuppressed, we know they have their own issues, but they should have been offered a 3rd dose to be considered fully vaccinated as well. And so, it was really problematic. And I think when you talk about the population level, they looked at this group of people And they said they made a decision based on this homogenous group. And we know that it's not a homogenous group. They said, on average, teachers are young. And therefore, because they're young, their risk is low. It ignores older teachers, ignores teachers who are clinically vulnerable, who were not shielded. Unshielded clinically vulnerable teachers were forced into classrooms. They were often told that they could not wear a mask because it interfered with their teaching. They were not to be masking, particularly with younger children. I mean, we had horrific stories coming from our members. We had many teachers in our group, teachers who were incredibly vulnerable and who were being told, that they had to take their masks off. And it was awful, just absolutely shocking situation. So they couldn't even protect themselves. In terms of access to the vaccination, I think certainly we would have liked to have seen, because there are two factors here, and I think we need to kind of divide this up to make it clear. There's your risk, your innate risk that you carry due to your age, and other health conditions which make you clinically vulnerable. But there's also, and that's a scale, that and some people might be kind of like off the edge of the scale, but still on that risk profile, but not enough to be prioritized. But there's also there's your exposure risk. Professionals were prioritized based on their exposure risk to keep healthcare running, and to stop transmission or reduce transmission based on that particular issue, and keep them in work ultimately and keep everything going. But teachers and schools were not considered in the same way. And although, as you said, they were surrounded by these children who, despite what the government told us, did catch and spread COVID, and it would be shocking if this kind of cold type virus, that children aren't the super spreaders of this one, but only this one, we kind of didn't believe that. But also, I think that there was a situation that, I mean, they could have not necessarily prioritized teachers, but they said potentially they could have moved up those clinically vulnerable ones. I would have liked to have seen the people who had both of those risk factors moved up. If they had an exposure risk, then maybe we could have given them the mop-up doses at the end of the day, where you had to use these vials up. And then certain people, if they had connections, they knew somebody who was a pharmacist, they were going in and picking up these mop-up doses. But actually, we should have prioritized those and said, maybe the teachers can go and get these now, or I'm sure there's a way of doing it where we could have had a better outcome.
Lara, I'm so sorry for everything that the members in your group have suffered and continue to suffer, and the obstacles that have been put in their way. I think it's disgraceful, and I'm sorry that so many of them continue to live as they do, and that they seem to have been forgotten. I wonder now if we could talk about maybe our standout moments or standout witness of week 2, module 4. I'll start. We haven't talked about him, and it was Professor Wei Shen Lim, who is the Joint Committee on Vaccination and Immunization COVID-19 chair. Why he's kind of my witness of the week is for someone like me who doesn't have a science background, who gets lost sometimes he was so clear in how he presented things, and he really made me understand vaccine strategies. He talked about direct and indirect and made it very clear. And he said something that I think is a theme throughout this whole inquiry. He said, advice alone does not save lives. It has to be disseminated and agreed and acted on, which seems to be the crucial step. Lara, can I come to you for your moment or witness of the week?
Well, for us, it has to be Dame Kate Bingham, without a doubt. I mean, she's been absolutely amazing at providing the information that we really need to get out there. We need the government to know, we need the government of today, when I say this, we need the government of today to appreciate the significance of this and how this group have been left behind, and how maybe there's something that we can still do. And for us, it's very much about what we still need to do. We're still in this fire, it's going to continue burning, and we still need access to treatments. We still need access to vaccines. And I don't know if you're aware that the JCVI, Wei Shin Lim has sort of written something to say that Basically, they have advised against many millions of people receiving their COVID vaccines this autumn coming. And so, they're going to reduce the vaccination group for COVID down to a very small group of just people who qualify based on being severely immunosuppressed, people in care homes, and the elderly, I think over 75s. And everybody else who might qualify for a flu vaccine will not be offered them anymore, despite the fact that, each year since 2022, we've had a twin-demic, a triple-demic, and this year a quad-demic. When are we going to learn, and why would taking vaccines away from this group with this constantly evolving virus be a good idea? I don't know. But yeah, and access to therapeutics, which still remains a problem to this day, and people are not aware about the treatments. They're not aware of how to access them, and people still struggle.
Just on from what you said, I know I'm a volunteer at the National COVID Memorial Wall, and every week or two we update the number of COVID dead in the UK. COVID isn't over. People are still dying of COVID at a rate often of 200-300 a week in the UK. Nicola, last but never least, what was your moment or witness of the week?
So my person of the week didn't actually appear in week 2, but it's Dame June Rain. Now, she is in charge of the MHRA, the Medicines and Healthcare Products Regulatory Agency. So they were in charge of basically saying whether a vaccine was authorized or an antiviral was authorized. Why is she my person of the week? Well, for reasons I don't entirely understand, both Professor Chris Whitty and Jonathan Van Tam were very, very nervous about her coming under pressure. So Chris Whitty said, "We wanted to make sure that Dame June, she was under a lot of pressure, felt that if there were any pressure brought to bear on her, that she could talk to Sir Patrick or me, and we would do our best to counteract that, because I was very worried at that point in time, if I'm honest, that otherwise the pressure would be applied, and I made it clear that that was what I was doing in government." Jonathan Van Tam said, "I lost count of the number of times I would have a telephone call with Dame June and said, 'June, at all times, if you think I or anybody else in the wider system is nudging you or treading on your toes in some way, put the phone down and complain about it, because it's absolutely sacrosanct and important that your work remains independent.'" Why were they both so nervous about pressure being put on the MHRA? And why were there no follow-up questions asking them, why were you nervous about this? Who was that pressure potentially coming from? What was the pressure to do? So that's my person of the week, this person who apparently needed protecting. Why was there pressure being put on her?
Thank you both a lot. We have one more week of this module to run. It's been a really interesting module. Laura, thank you so much for coming and talking, and also thank you for giving your testimony. It takes courage to do something like that, and I'm full of admiration.
Thank you so much for having me, and I just hope I've raised enough in my statement.
Thanks, everyone.
See you next time.
Thanks for listening to this instalment of the COVID Inquiry podcast. We hope you found it insightful and interesting. If you did, please rate us on the podcast platform you use and share the pod with friends and family who may value this type of commentary. We're looking forward to you joining us next week for more expert commentary, opinion, and insight into the COVID Inquiry evidential hearings.